Hello and welcome back to Psychology 303, the analysis of everyday behavior. I'm Dr. Williams, and we're going to be talking about Chapter 24, applications for respondent conditioning, specifically fear and anxiety reduction. Here's a little Far Side cartoon that you might enjoy. Professor Gallagher and his controversial technique of simultaneously confronting fear of heights, snakes, and the dark. I don't think I want Dr. Gallagher to be my therapist. Thank you. All right. So we're going to be talking about fear and anxiety and how we go about reducing that. And people have fears of lots of things. Fears of the dentist, of animals, of needles. And so let's talk a little bit about applied respondent conditioning, because that's really what we're talking about. Over the last century, since the late 1950s, the study of reflexes, desensitization, in vitro desensitization deals with the use of imagination and your ability to think about things that you're afraid of. And sometimes phobias are first treated that way, not actually in the situation, but through imaginal therapy. And then, of course, in vivo desensitization means that we move out of the clinician's office and out into the real world, where we actually expose ourselves to the objects or situations that provoke fear, so that we can learn to deal with them. Exposure therapy, on the other hand, it is handled in two ways. One, some people call it flooding therapy or extinction therapy, and then there's modeling. And this is where you are exposed to the feared stimulus or activity in full strength until your fears begin to reduce and you get more comfortable in the situation. So we're going to talk about these in a little bit more detail. But let's start first with what is fear. Fear is hard to define. It develops out of a result of both respondent and operant behavior. It's the result of both respondent conditioning and operant conditioning. The respondent fear, this reflexive fear that we have, often develops. This is a fear of an object or an activity or a location, and it usually develops through classical conditioning experiences. They can be personal experiences that can lead to the development of phobias, or they can be modeled experiences. We can watch things on television. We can watch things. We can watch other things happen to other people and develop fears. And then those fears are negatively reinforced through escape behavior. The client has developed a fear of an object or an activity, and now makes exerted and genuine efforts to either escape or avoid that activity or object or location. And successful escape or successful avoidance of that object, of that phobia, actually strengthens the phobia. It makes it worse. And through negative reinforcement of escape, it can lead to generalized anxiety to activities surrounding the phobia. So it can actually spread to other things. So let me give you an example. Fear of flying, fear of airplanes. It can develop through respondent conditioning. You can see a scary movie about flying that could terrify you. You might be witness to a plane crash. You might know someone who was involved in an air accident, or you might have been actually in an airplane and had a bad experience. Either way, you develop through respondent conditioning, you develop a fear of airplanes, a fear of flying. And when you avoid flying, when you opt to drive, or when you take the train, you are effectively avoiding your phobia, and you get a lot of negative reinforcement out of that. Turning down chances to travel where plane flight is necessary. all of these things can strengthen your phobia or your fear or your anxiety through escape or avoidance through negative reinforcement. And then it can generalize. So you may start out seeing a movie that scared you. Now you're afraid to fly, so you avoid flying. You turn down opportunities to travel because you'd have to fly. And then you start to discover that you're developing anxieties related to even being in an airport or near an airport. It might even generalize to other experiences that are similar, like being on a train or any kind of public transportation. And so it starts to spread. And so you can see how this combination of respondent conditioning and operant conditioning together can create a real life-imposing situation for people. They can actually feel their lives made smaller through this escape and avoidance of the things that they've learned to fear. Okay, so lots of different types of phobias. There are 3 general types of phobias. The first one they're called specific phobias, and there are 5 general types. Animal phobias, so people who are afraid of dogs or spiders or mice or snakes, any kind of critters. Environmental phobias, where people are afraid of the natural things in our natural environment. So things like lightning or thunder or aging, part of the natural process, or things like afraid of highways or afraid of bridges, which are just part of our environment. Then there are situational phobias, where people are afraid of small enclosed places like elevators, or people who are afraid of the dark or afraid of boats. So they're very situational based. There are medical phobias, where people are afraid of certain kinds of injuries or have a phobia about blood or about surgery or about needles. And then finally there's the other category, where people they're very specific phobias, but they don't fall into any of these 4 categories. So things like being afraid of clowns or being afraid of babies, being afraid of televisions. That category is an interesting category because they're usually very, very specific. And at any time, anywhere from 8 to 12% of the general population has a specific phobia. Oh, sorry about that with my cursor. I apologize. There we go. A second type of phobia are social phobias. These are fear of social situations that they're generally, they can be put into a general category called social phobias because they're situations that invite scrutiny by other people, where the person feels like they're becoming the focus of attention, or situations that could be embarrassing or humiliating. And so examples include things like people can be afraid of public speaking, or afraid of dating, or afraid of parties, or of talking to large groups of people, or talking to strangers. Some students are it's phobic. And so the symptoms that are associated with these social phobias are things like blushing and excessive sweating, trembling, nausea. You might have palpitations. You might find yourself stammering or stuttering. And so these social situations can be difficult for some individuals. And then, here we go. The last type of phobia that I wanted to talk about is a very specific type of phobia called agoraphobia, which translates literally as fear of the marketplace, but it's really characterized by symptoms of anxiety in situations where the person feels like the environment is not safe. So they're in a location or a situation where they feel like it's not safe and there's no easy way to get away. This might be just open spaces. It could be being on public transit or being in shopping malls, or for some people, it's simply being anywhere other than in their home. Even something as simple as being out on the front porch can be enough to provoke extreme anxiety. And being in these kinds of situations can even produce panic attacks where people think that they're going to die. They can produce other symptoms like separation anxiety or PTSD or major depressive disorder. And the people who experience agoraphobia are at very high risk for depression and for substance abuse. So clearly this is another type of phobia that needs to be handled. So this is just a list of a few common phobias. If you go into Google and you type list of phobias, you'll get pages and pages and pages of phobias, and some of them are very interesting. These are some of the more common ones, things like fear of heights, fear of dogs and cats, fear of fear of responsibility, fear of diseases, and then animals, of course, snakes and fish and spiders. But the other things like fear of mirrors or the fear of the cold. Some of these can be the fear of seeing someone naked. That could be terrifying if that was what your fear was. Fear of dirt, fear of bacterial contamination that leads directly to OCD kinds of behaviors. So there are lots of phobias. This list is very short compared to the big lists that I've seen online. Okay, so what do we do about these fears and anxieties that are out of proportion to the threat that is actually posed? And there are your book talks about 4 basic relaxation training procedures that can be used by themselves or are used as part of other therapies like systematic desensitization. The first one is progressive muscle relaxation. There's also diaphragmatic breathing, attention focusing exercises, and behavior relaxation training. And I'm going to talk about each of these a little bit, and I've got some videos for you to watch. But there are 3 components that are true of all of these methods, and that is that they involve muscle relaxation, they involve relaxed breathing, and they involve focusing your attention. And any kind of anxiety-related therapy will usually involve some kind of relaxation training, and it could be any one of these 4 types. So at this point, I'd like you, rather than going through a big list of me just telling you what's in your book, I thought it would be much better to give you other perspectives. So I have 3 videos that I'd like you to go and watch. So if you pause the PowerPoint and go to the assignments and lecture videos section under assignments, you can watch short videos on progressive muscle relaxation, on diaphragmatic breathing, and on attention focusing exercises. They're all really good. I don't have a video for behavior relaxation training. This is a method that's used to make sure that every part of your body is in a relaxed position, that there's no tensing and relaxing of muscles. So when we talk about PMR or progressive muscle relaxation, where we tighten up muscles and then relax them, behavior relaxation doesn't do that. It simply has you do an inventory of the position of each part of your body to determine whether it's tense or not. And if it is, then doing what you need to do to relax it and then moving on. So you're not actually tensing and relaxing. You're just doing an inventory and relaxing those parts that seem to be holding the tension. So why don't you go and watch the PMR video, the diaphragmatic breathing video, and the attention focusing videos, and then come back and we'll go on and talk a little bit more about systematic desensitization. Okay, so let's just talk a little tiny bit about systematic desensitization. It was developed it was actually first published in 1958 by Joseph Volpe, who was a South African psychiatrist, to help people overcome anxieties and phobias. Pardon me for a moment. So, Volpe's theory hinged on the basic idea of reciprocal inhibition. And this theory of reciprocal inhibition was that a person cannot be anxious and relaxed at the same time. So if a client can learn to relax in the presence of a feared situation or feared object, and they can stay relaxed, then the anxiety should subside and the amount of fear they experience should be reduced. So in short, relaxation is supposed to short circuit the anxiety that you're experiencing. Okay, so there are 3 steps to systematic desensitization. In the first step, the client learns relaxation skills using the methods that we've discussed previously. And they do that during the sessions, during their therapy sessions. The therapist might send them home with video tape homework where they observe, watch a video, and then practice at home. And they might do this for a couple sessions. Once the therapist feels that the client is beginning to master the relaxation skills, they will begin to meet with the client to develop a hierarchy of fear-producing stimuli. So, for example, if I come to a therapist because I have a fear of dogs, and I've got a roommate moving in who has a dog, and so I need to deal with my fear of dogs, the therapist is going to, for several sessions, we may spend some time talking about all the possible situations where there might be a dog in some way in the environment, and how on a scale from 1 to 100, where 1 is the least amount of fear and 100 is the most amount of fear, how much, on that scale of 1 to 100, how much does each possible situation provoke fear? The therapist then ranks all of those fears according to their hierarchy. This way we have a list of the least provoking situations to the most provoking situations. So the least provoking situations might be something like seeing a dog on television or seeing a dog in a magazine. Maybe a little bit higher, or seeing pictures of dogs that belong to people I know. Or someone visiting who has their dog in the car. And each time it increases in terms of how much anxiety it produces, all the way up to having a dog in the room with me, having a dog sniff me, having a dog jump on me, having a dog jump into my lap, having a dog lick my face, having a dog bark at me. All of those might be really high on my hierarchy. And so we develop this hierarchy of fears together. And when the therapist feels that the client is really ready in terms of mastery of the relaxation skills and a really thorough hierarchy of feared stimuli, then the client leads, the therapist leads the client through this hierarchy, either in vitro through imagination or in vivo live with real dogs, while the client practices his or her relaxation skills at each level. And we start at the very lowest level, and we may use both in vitro and in vivo. So we might start out with, imagine that you're sitting in your chair in the living room, and a commercial comes on and there's a dog in the commercial. How anxious are you? On a scale from 1 to 10, how anxious are you? And then now I want you to practice your relaxation. I want you to relax your muscles. I want you to breathe, focus on your breathing. The dog is still on television, but I want you to breathe, listen to your breath. Where in your body are you anxious? Where are you holding your tension? Relax that part of your body, and you work all the way through. And periodically, the therapist will ask the client, where are you on a scale from 1 to 100? And what happens is the more time they spend relaxing, typically the lower that number gets over time. And the therapist only moves the client to the next the next feared stimulus in their hierarchy when they feel like the client has reached a comfort level, a completely comfortable level with the stage that they're at. And then you move on to the next stage in the hierarchy. So here's an example of a hierarchy. This is a arachnophobia hierarchy with the fear ratings on them. So here I'm going to use my little cursor. So the lowest level is thinking about a spider, produces a fear rating of about 10. Looking at a picture of a spider, looking at a real spider in a closed box, holding the box, now we're up to a rating of 60. Letting the spider crawl on your desk, letting it crawl on your pant legs, now we're up in the 80s and the 90s, and then all the way up to actually having a spider touch your bare arm. And so they might build this hierarchy, and they're going to start at the very bottom just thinking about a spider, and we won't move up until they can think about a spider without any anxiety after using their relaxation techniques. Okay, so I'm going to have you pause the video, the PowerPoint here, and go to the assignments, lectures, videos for Unit 8, and watch videos 24E and 24F that are both about systematic desensitization, and then come back and we'll talk about some other therapies that can be used to treat fear. Okay, other therapies for fear include, one of them is exposure therapy, also called flooding. And this is where the client is exposed to the feared stimulus at its full intensity for an extended period of time until the fear subsides. This is a very intense kind of therapy. Gradually, the anxiety decreases, but it's believed that the reason that anxiety decreases has to do with some combination of respondent extinction and exhaustion. The CS stimulus is presented, so this fear-producing stimulus, this a dog, a puppy, is presented, but there are no negative consequences, and there's no escape. This technique requires a professional therapist because if someone attempts it, that should say alone, that should be an E. Here, I'm going to fix it. Come on. There we go. If attempted alone, there's the risk that the client will escape the feared stimulus while they're still anxious. They might be extremely anxious because we're talking about the full-on highest feared case of the stimulus. And if they then escape that feared stimulus while they're still super anxious, it will actually strengthen the fear, make the fear greater, and increase the anxiety for the future. So we have to be very careful that the individual doesn't successfully escape the feared stimulus until the fear subsides. And so this is very intense. It can take many minutes. It can take hours. So it's quite a powerful method. And right now, here, let me show you some pictures here. Exposure therapy is used here in this. We have a photograph of, here, I'll use my cursor. Over here, there's a woman, there's a snake in this man's lap, and she's going through exposure therapy with snakes. This woman is going through exposure therapy with spiders. There's a tarantula in the box that she's holding. And one of my favorite ones that I think is so interesting is the use of virtual reality to engage in exposure therapy with former military suffering from PTSD. It's been shown to be extremely successful. And so what I'd like you to do now is, in a minute, I'm going to have you go watch a few more videos. But first I want to talk a little bit about modeling exposure because it's related to exposure therapy. And modeling, here the client doesn't actually engage in the feared activity themselves at full strength, but they witness someone else doing it. So they watch another person handling the snake. They watch another person who's afraid handling the rat, or dealing with the elevator or the escalator. whatever it is, they watch other people do it until their own fear subsides enough that they're able to do it themselves. It usually results in a decrease in anxiety for the client. It may not go to zero, but sometimes the modeling helps them then jump in to do the exposure therapy for themselves. So it could be that the modeling alone is sufficient, or it can be used as part of a hierarchy in the systematic desensitization therapy. It can be one of those hierarchy items that says, seeing somebody else pet the dog is not quite as bad as me petting the dog. And so I'd rather, that it would also make me afraid to watch someone pet the dog, but not as much as it would make me afraid to do it myself. And so you can put it into your systematic desensitization therapy as well. Okay, so virtual reality flooding. I want you to, this is the last slide, so I'll have you end the PowerPoint and go back to the assignments and lecture videos for Unit 8, and I want you to watch the last two videos, G and H, which both deal with the use of virtual reality being used for exposure therapy or flooding. All right, so have a great day, and good luck on the exam.